Hi, I'm Ralph Preston, and on Tuesdays we have these Stroke Buddies Recovery and Science Zoom meetings where we hope to bring you some information that will prove to be valuable to you in your recovery, because that's what it's all about. And today, back for the second time, we have Dr. Jennifaye Brown. She's a doctor of physical therapy and an expert on a number of things, women's stroke and AFOs, and today she's going to kind of combine those two subjects. So, without any further ado, let's welcome Jennifer, and thanks for taking the time to put together a presentation and presenting to us today.
Hi, everyone. I'm in Charleston, South Carolina, so you may hear some thunder. It's hot and humid. So I'm going to make some corrections. I don't have a doctor in physical therapy. I went to school when it was an entry-level master's degree.
Oh, sorry.
That's all right. My PhD is in exercise science, and I did my doctoral work in stroke rehabilitation and health disparities and health outcomes. So, this is Women in Stroke number 2, AFOs and exercise. But I am so glad to see so many gentlemen here because you're going to see two sets of pictures from a gentleman whose AFO was changed over time. But we're going to do a case study with a female with her AFO and how she progressed through exercises and eventually weaned out of her ankle foot orthoses. So, welcome everyone who's here on Zoom and by YouTube. Thank you for attending. So, I just told you I have a PhD in exercise science, but I've been board certified in neurologic physical therapy for 10-year terms. And I'm a certified aging in place specialist because all of my clients were going home and saying that, you know, children, spouses, caregivers, you couldn't stay here because you can't move around the house. And so I started helping people modify their homes and I became certified in that. And I think people should be able to age in place. They shouldn't have to go any place just because they have impairments from a stroke. I'm known as a stroke rehab sage, but I'm really a physical activity guru and exercise enthusiast because exercise and physical activity is what really matters after you've had your stroke. Again, I did my research on individuals with stroke regarding the perceptions of their AFO, how it's made, how it's fitting, how it's functioning for them, and health disparities. You see me in my aqua suit here because I'm cold natured. Number one, I can't stand cold water, but I have sickle cell disease and I am at risk for stroke. And the sickle cell disease has slowly been destroying my joints. And so the pool therapy is the best thing for me. And I have been using aquatic fitness um, for individuals with stroke, actually, a lot of neurologic diagnoses, but I'm mostly focusing on stroke prevention now and post stroke fitness. And I'm using the water as a medium for that. So I got to tell you all some things because morally and ethically it's the right thing to do. I do have a business where I do mostly consulting and teaching. And I wrote a book that you're going to learn about today. And so I get royalties from that. And anything and everything that you've heard today cannot be interpreted as medical advice. All right. Make sure you consult your physical therapist, your orthotist, your physician about making any changes to your AFO, your exercise program, your physical activity program. Thank you. So let's just do a review. Women in stroke. All right, this was from part one. Um, so women tend to live longer than men. So naturally, as we age, our arteries don't expand and contract like they used to. So we tend to have more strokes of the hemorrhagic type, where the artery will burst at a weakening in the wall, okay? Because it's just less compliant as we age. But we also have ischemic strokes, and that's from a clogged artery. So that's all the junk that you eat. Mostly now it's sugar. Cholesterol used to be the problem, but now it's sugar. All right. And women have a greater disability because they're up in age. They tend not to be as physically fit. And our hormones post-menopause have dissipated, and our hormones are very neuroprotective. They're good for the heart and good for the brain. We find that greater disability occurs post-stroke because we're underrepresented in acute inpatient rehab centers. Why? Because the people who come to inpatient rehab tend to go home and will be able to manage at home and have someone care for them. Well, women outliving their spouses, their partners, are usually single and don't have anyone to go home to. So they tend to end up in a nursing home or a cared living space, so they don't get the opportunity to go to inpatient rehab. So they often require nursing home placement for the long term. And we all know that once you get to a nursing home, the care is not that good. And because of that care is not that good, people, their health and outcome for their lifespan goes down dramatically. So I wanted to show you, this is just a picture of a blocked artery here, and then versus a ruptured artery here. And it usually ruptures in the weakening of the arm, of the artery. So a hemorrhagic stroke versus an ischemic stroke. And there's some unique risk factors for women that may cause a stroke, particularly at a younger age. For pregnancy, is gestational diabetes and increased high blood pressure during pregnancy. Birth control pill causes coagulation along with smoking. Your oxygen, nicotine binds to the oxygen of the red blood cells and makes it clump. And then menopause, we already talked about that. Menopause, your hormones are neuroprotective. And then the hormones that they replace, right? They're clot forming along with transgender hormones. They are clot forming. And then the stress of societal roles. And women tend to have what we call weathering more so than men. And it's that our DNA, they have these little caps on the end called telomeres, and they're frayed from the stress of what we do in terms of women. So we just don't stay home and care for kids anymore. We're managing the home, taking care of kids, and we're out working. So we have more jobs than norm, and that causes stress. So, what can be done for women for a better outcome? Well, we should get early and intensive rehabilitation, but that happens before we have the stroke. So, everyone now should be exercising or engaging in some physical activity. And I don't care if the physical activity is going to the senior center and playing bridge or playing cards, because that cognitive activity, when your brain is wired and move more, your body tends to move more, right? And then we need tailored support systems. If women are older and by themselves and are alone, maybe they need more counseling. So mental health counseling is important. And then probably we need more community-based social work interventions. Where can people come together? All right, or where can they meet in someone's home to age in place and do social activities that wouldn't get done in a public space? Social engagement is very important. As a matter of fact, I teach the chair exercise class, and this it's called strength and balance class, where most of the class is standing at a senior center not too far from me. And I just casually asked, how many people came to the class? Are you able to find out? Because I think I had 63 in there. And at one point, we were standing room. People were standing up in the chair exercise class because they wanted to be so much a part of it. So people really come to socialize. That social engagement is very important. So the other thing we have to do is address unique risk factors, things that women experience as they age. And sometimes I don't think physical therapists look at gendered roles when they're doing the rehabilitation program. So now we're going to start Women in Stroke Part 2, which is my AFO research. So, the AFOs that you're going to see in these pictures are not those of the people who were in the actual study. You know, after a certain amount of time, I agreed to destroy everything. So that means getting rid of the videos, the pictures, You won't see anybody's names. So an AFO is an ankle foot orthosis, and that's coming up in the description below. I tend to say individuals with stroke and not use stroke survivor, because when you put stroke first, you put the emphasis on the stroke and not on the person. And I want the person to have the autonomy, the belief, and the control that they can do things despite the disability as a result of the stroke. So I'm really holding the individual accountable and not blaming the stroke. Okay. And I don't want to emphasize the stroke either. CVA is a cerebral vascular accident. As you know, there are two types, ischemic and hemorrhagic, which is a bleed. And then the ankle foot orthosis. This is what's important about this foot and leg brace. It should pull your foot up, but not stop your leg from coming forward. So when you think of your leg coming forward, that means your knee, when you go to sit to stand, your knee should be in front of your ankle. And then when you're walking to take a step with the opposite leg, your knee and your hip has to come in front of your ankle. If you're wearing a brace and it stops your knee and your hip from going towards your toes, you have a problem. And I have a solution for that. PTs are physical therapists, OTs are occupational therapists, and HCPs are healthcare professionals or healthcare providers. So here's an example of an AFO. And this person complained about their AFO because it didn't fit him properly and it didn't function for him. So the first of all, I want you to see at the top, it had the plastic that came around the front of his leg. And then it had a Velcro strap that went through a metal loop and wrapped back around. He could not move his knee forward and his leg kept snapping back. And then he had this strap across the ankle that went through this metal and came back. Because adding that metal, the shoe that he purchased had to be extra wide, let alone longer because of this toe plate. And if you notice, the toe plate is higher than the rest of the AFO, and the AFO is relatively flat, but they added some liner to accommodate his foot. So the first thing I started doing is I was trying to make all the AFOs so that they would not block the knee from moving forward. Second thing is you are never in a state where your toes are always higher than the rest of your foot like this. It's only higher when you're ready to push off and you want to walk faster. And that means the toe plate needs to be flexible. All right. So all of my AFOs, if there's a toe plate where the toes are, it's really flexible. If you look at the middle picture, no one's toes are this flat. Even if you have a flat foot, which is pronation, you still have a rounded arch here. So I tend to make the forefoot of the toe plate a little rounded and the big toe a little lower than the rest of all the rounded parts of that transverse arch. Now, this is the same AFO. I don't like wasting things. And so I try to modify all of the braces that my clients come with. And I did two simple things. I asked them to heat up the toe plate and round it out so it wasn't flat, and then heat it up so it was flat compared to the rest of the foot, but could bend so the person could roll over their toes. I took off that strap with the metal loop and I said, let's just do a Velcro strap. But I wanted to start from the outside of the ankle and go down towards the base of the little toe. Because when you have that double strap right across the top of the ankle, you press down on the tendon that's connected to the muscle that pulls your foot up. And you're quietly making that tendon sick by compressing on it. And when I say sick, you're making it weaker. So I say bypass the tendon, start from the outside and come here at the base of the toe. And that helps your foot go down because most people who have a stroke, their foot is down and rolled in. So when you start the strap on the outside and come into the middle, it brings the foot down, allowing the knee to come forward. And then the next thing I did was I shaved off the part of the plastic that was coming forward. If it's coming forward, it's blocking the knee to come forward. All right. And so the last thing I did was add a spandex strap at the calf. And so I have different tensions of calf straps, and I use them across the ankle depending on how weak you are. You can get these in different colors now. I used to get this from 3M. You can go to a craft store and get them, but I have these bandages that stretch based on how weak the person is. All right. And not just weak for the muscles in the front to pull the strap up, but weak for the muscles in the side of the leg that turns your foot out. That's called the lateral compartment. And then your calf muscles and two other muscles in the back of your leg. That's called the posterior compartment. So now this gentleman is able to ride a bicycle because his tibia can come forward, his leg bone, there's two of them, tibia and fibia, and we'll just call it the leg, can come forward. That's my finger behind his calf muscle. For everyone who has an AFO and the shaft goes straight up, your calf muscle won't be able to expand and contract, so it wastes away. So I would say 90% of my AFOs don't go above the calf. And I think the reason that is because I start an exercise program early on where it doesn't have to have an AFO that goes up. Now, there are some instances where I do have to have it go up, and you're going to see some pictures, but every AFO is different. And it's different based on the person's height, weight, BMI, the type of shoes they like to wear, the type of work they have to do. So that I take all of that into consideration. All right. So when I looked at this part of the research section, I'm going to explain the research study and its significance, and then I'm going to provide some topics related to AFOs that you should be discussing with your physical therapist, occupational therapist, and the orthotist. And that's based on my research, my clinical experience in the book. And then I'm going to answer any of your questions about AFOs and exercise. And we will have a case study at the end. So for anybody who's present now, does anyone currently wear an AFO or has had one in the past?
Yes.
And what did you like about your AFO or did not like about your AFO?
I like that I get to choose the pattern on my AFO.
That's nice. Choice,
Oh,
control, the ABCs. Yes.
Holly, I love your AFO. It looks so thin. I just got my AFO redone because for the past 4 years, I had the AFO that Dr. Brown showed us, just in black. It had a strap in the bottom and it made me walk like if I had a stick leg. So now I'm trying to relearn how to walk. They adjusted my AFO. They gave it hinges. They said, sorry, it was during the pandemic. We were not able to size you. So my new AFO is extremely clunky. I hate it. It
Okay.
almost takes up my entire leg and it's hot. It has the hinges, but it's just, I mean, I can't wear my regular pants or shoes with it.
Mm-hmm.
So I saw
Yes.
Polly's and I'm wondering where she got that AFO. It's very
Okay.
Well, when I first had the stroke, I was given an AFO that looked just like the leaf spring AFO that Dr. Brown was showing.
This is a leaf spring.
And I wore that for a good 3 to 4 months before a PT referred me to an orthotist. And I was given, you were talking about, and that was my question for you, was what about an articulated ankle? I thought that was really important. Like you were talking about the tibial translation.
Mhm.
And I noticed, yes, you said you were trying to work with what they had, but would it have been better to go back to the drawing board with that one and have an articulated ankle?
So this is why I don't give an articulated ankle anymore, and I haven't done it in over 25 years. Number one, they're expensive.
What's an articulate? I'm sorry. What's an
The
articulate?
hinge that you were
It's
talking about.
hinged. Can you look at the picture right here,
Yeah,
Erica? You see the little hinges on the side?
yeah. Let me
You
just
see, you
this.
see how wide this is? And do you see that
Yeah.
the bottom is not encapsulating her heel? So
Yes.
it's so wide because of the hinges, it's not encapsulated. And do you see how her heel is turned in and it's rubbing against the inside?
I
All
look
right.
like I have that problem too.
And
Yes.
it's uncomfortable. Okay. And so I'll tell you some exercises to fix that. All right. Um, so that's one reason why I didn't give out the hinge. But guess what? You didn't need a hinge if your heel was seated correctly in the AFO and your tibia could come forward with the spandex strap. And so that's why I give out the spandex strap. Okay, here's a second thing. Those hinges have a plastic on the side or it's metal. I haven't found a person who's strong enough yet to cause the hinge part to come forward. They don't have what we call eccentric control of their posterior calf muscles. And so you can't force the hinge part forward if your foot is flat, and then the same muscle that pulls your leg up, if the foot stays flat, you need to use your tendon that's covered up like this to pull the leg forward to generate the muscle force. See, the muscle works two ways. It pulls your leg up, but when your foot is flat on the ground, you pull your tibia forward. Well, you can't do that when there's a strap across the ankle. So most of these hinges, these people aren't strong enough to pull their body forward or eccentrically allow it to come forward with the posterior calf muscles. And that's eccentric work. So the muscle's working two ways. Closed chain concentrically means it's shortening to bring the tibia forward, or the calf muscle is working eccentrically to allow the leg to come forward. And my number one pet peeve with physical therapists, oh, use a sheet and pull your foot up. Try to pull your foot up. No one's working the muscles in the front, side, or back of the leg three ways: isometrically, concentrically, and eccentrically. And you will see that in the case study. So, Polly, my only concern about your metal one that you have with the little, it has a little half spiral. Did they put something on your foot plate to make it comfortable? And wearing that brace with that same strap, would you be able to bend down and pick up $100 off the floor with both of your knees evenly bent?
It is not metal, it is carbon fiber.
Okay,
And yes, I can bend over and pick up things off. I'd pick up a dollar bill off the floor.
okay, so and both, and because that the strap that you have is not flexible. It goes in and around. So that's the first thing. It goes in and around a loop. And then it's a carbon fiber. But if you would have hit it on a surface, it would go cling, 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 right? Because it's not really bendable like that. It has a hinge part.
Now
Okay.
mine is stiffer because I don't need the dorsiflexion assistance. I need the ankle stability.
So
So
Yeah.
your ankle is rolling out. And so you want to protect it from rolling out.
yes,
Is that
so
what you're saying? Okay,
it's
so
built
from
up.
rolling out. Okay. But I guarantee you, once you limit with that force, okay, with that force, if you were to just take yourself in the mirror and I looked at you from the sagittal side, there's a compensation someplace because you got to give someplace on the symmetrical movement of the knees and the tibia turning for you to come forward. So I've seen a lot of people, and you know what else that's allowing you to bend? It already has a curve in there. It already has a curve, so it makes it easy. Yes, Erica.
Thank you. I wanted to ask a question
Yeah.
because my therapist wanted me to get the hinge brace and I got it, but I don't like it. So I'm actually going back on Thursday
Uh-huh.
to have my old brace adjusted. And
Okay.
he's very nice. He's adjusted it, thinned it out a lot for me. So
Uh-huh.
there's sandals and things, and
Uh-huh.
moved the straps. So my question is regarding the straps. I'm gonna ask him for stretching and see if he could do
Yeah,
that.
ask them for a bell stretch and don't
And
have it blocking your tibia from coming forward. You need to look at the foot and tell them to look at the foot biomechanics, the hind foot, the midfoot, and the forefoot. So you have to walk barefoot with support so he can see that. And then I'm going to show y'all some other things. If you can get to that, if you can get my book and take my book to your appointment and have them go through the chapter what the physical therapist should measure, that would be a great asset to you so you know what to ask him. I have a whole chapter in that book
and
for
what's
what
the
you should
title?
ask him.
What's the
It's
title
at
of
the
the
end of this PowerPoint, and it was in the introduction when you got the invite to but it's called Brace Yourself. It's a long title. So at the end of this PowerPoint, it'll be on there. But brace yourself with my name. It'll automatically come up.
Thank you, doctor?
Okay,
Okay,
so we
can I ask you a
understand that,
question?
yes.
All right, I'll show you mine. Mine's kind of ridiculous, but
Yeah, I see your hinge, and that's a common hinge.
no, it's not actually.
Well, for me,
It's
it is, in my experience. I've seen that U-shaped hinge before. Uh-huh.
it's actually got pistons in it to make it
All right, so
adjustable.
yeah, and it bounces and it waits. All right, so the piston and it feels the pressure and it gives some back and there's a release.
Yeah, it does, but it's not. He's got it maxed out. So the problem with mine is that I have lots of inversion.
Okay,
Um, so
so hold it back up. Hold it back up. Okay, so he has lots of inversion. So his foot is turning in like this, but look at his heel of the shoe. And then look where his straps are it's not facilitating pronation or eversion, which is the opposite of the inversion. And explain to your classmates or the people here about it's maxed out for you. I like the term.
so right now because the thing is, this is one of the things that I want to bring up is that if you even got the right articulations in place, but if your calf, for example, if your calf is so tight, your muscles are so tight, you can't really get the the
You can't generate the force, even if the brace is supposed to help you. You've got to activate it to work. Am
yeah,
I close?
because if it doesn't work, if it's too tight, then you don't get the angle that you need to actually get the heel strike moving forward. You know what I mean?
Right. And so this is why sometimes you have to train a muscle in reverse. So, how do can I say Kim or is it Musong?
Song. Yep, you said it
Musong.
right.
Thank you. Did they ever train you in that brace walking backwards?
No, but I can't
Okay.
really. I mean, I can walk backwards, but it's very slow.
It's very slow. So when
Yep.
I tell all of my therapists this, train the person in the brace to walk backwards because you're treating the calf muscle like a spring. You're stretching it. And when you stretch a spring, it absorbs all the energy in between the coils and then it goes like that. And then you can push off and walk further faster. But you can only walk further faster if your toes are not blocked at this part or you have a flexible piece. So that's why I tell them to go backwards. But I had someone who was in that brace like that, and I said, whatever you do, I need you to loosen it so it can have 3 degrees of freedom. And I want them, when they push down, they need to have enough force in the spring to push down so it helps to relieve and vault them off. And I said, if you have to change the springs in it, do something. But that person had the brace and they were falling all the time. I said, we got to change the mechanism in the hinge because I haven't trained them yet to work with the brace set at that. So it's a fine tuning. It's a fine tuning of the brace. Yes, Chris,
Uh, are you familiar with the extern frontier?
say it one more time.
Extern frontier.
Extern frontier. No, show me a picture.
Well,
Probably know it by picture.
it goes down the outside of
Oh,
the
yeah. Yeah.
outside of the shoe.
Yes, I've seen those. Yes.
Yeah, I had to fit in last week, and
Uh-huh.
everything went, and it certainly gives me more confidence. The only thing is, my glutes are complaining something awful, so I'm guessing I'm waking up muscles that have not been used recently. Is
Yes,
that
you
normal?
are. Okay, like Polly's, did you notice how your AFO is angled forward?
Yes.
It's already angled forward. You're working your calf muscles, the two ones that are straight and the one that crosses the knee joint. You're working your posterior tibialis and the plantaris muscle. Yes, you're working them. And when your leg is angled forward, the ground reaction force goes in front of the ankle, but behind the knee, and your knee stays a little bent. So now you're working your quad muscle, the muscle in front of your thigh, in a term we call eccentrically. Not that much, because I know you're not pushing back on that all that much. You're a little angled forward. So that's what you're probably feeling.
Well,
Okay.
the other thing is the physio said, "Oh, I see you're walking with a bent knee." I said, "Well, that's
Yeah.
because my knee used to snap back." He said, "Try walking with a straighter leg," and I did that, and it worked fine. It worked fine. The AFO supported it well, but of course
Okay.
that does turn on the glutes quite a bit.
Yes, it does. And that's what we're missing in walking. We are so every therapist says straighten the knee, straighten the knee. But when you're standing up and you're swinging the other leg through, your knee is quiet at 0 to 5 degrees. It's not on tight isometric. It's your glute muscle that you powered up to get your knee over your hip, plus the momentum from the other leg and these ligaments in your knee that helps keep your knee straight. It's not tightened. And the only thing I would say, if you're having to straighten your knee so much because you feel like you're falling forward because it's angled that way, that's your reaction to what the brace is doing to you. So when you go to therapy now, you can have the brace on and then start exercising and doing tasks with it unstrapped, with the shoe on, the brace on, but unstrapped. And then a portion of your therapy should be with the brace off, wearing a normal size fitting shoe. So I have to tell people to bring 2 sets of shoes to therapy, the one that fits the brace and the one that fits your foot without the brace. Okay.
Yeah,
All right.
thank you.
Good activity of talking. All right.
Can I bring up one more point just to clarify?
Yes. Uh-huh.
So on the going back to what my situation was about articulation, because
Yes.
even if you got the right articulation on your brace, but if your gastroc is too tight and it won't like does
You are
because
absolutely right.
because you're just not wired up. You're not wired up. It's still offline. Your gastroc, if it's so tight, it doesn't matter how much articulation you have,
You're
right?
right. So,
Okay.
Masam, you're absolutely right. And I'm going to get to that at the end of the presentation. I bet you
Okay.
your physical therapist didn't measure your ankle in 3 positions in 2 different ways in each position. I do 6 measurements to
Yeah.
test the mobility at the ankle joint. So if your gastroc, is it that your gastroc muscle is tight or you have tightness at the Achilles tendon? Because if your heel cord is tight, the Achilles tendon, you're going to do something called pistoning in the brace. And that's why they add the strap across the top of your ankle to force the heel,
Yeah. I forgot to
down
show
and
you.
back.
I have this boot that goes inside
Yeah,
there too.
right. And so it's not going to stay if your heel cord is tight. So sometimes I have to make a recommendation for a heel cord lengthening procedure. You do the dots or you do the Z lengthening. I don't do the Z's anymore. I don't recommend the Z's. I do the hole punching. But I'm going to show you some exercises that will
Okay.
help with that too.
All right.
Okay, Erica, I see your hand raised.
Just another quick question, since I'm going on Thursday, maybe I'll bring
Uh-huh.
braces, but I was going to ask you, should he be adjusting this brace that has the strap a little above the ankle? Or the
Yes,
one with the
because both of them, because it's going to block your tibia. You need to try both of those on with the shoe that you prefer to wear. The one that has the hinge is so flat on the bottom, that would be uncomfortable. You're not going to get your heel rocker, your midfoot rocker, or your toe rocker. And all of that is in the book. Okay, again, the AFO is not going to be perfect. You're going to have to give up something, but you're giving up the least thing that's not hurting your walking.
Yes,
You
ma'am.
want stability, but mobility. Okay. And so you may have a hinge that offers good mobility. All right. But if, like Musong said, if your calf muscle is tight, okay, or if your Achilles tendon, the tendon is tight, you can have all the flexibility in the articulation that you want. But if you don't have the muscle extensibility, it's
Right.
not going to work. Yes, Polly.
Yeah.
I need to answer your questions and Erica's question, and they kind of
Mhm.
go together
Mhm.
because it was 2 years after the stroke, and I went to my orthotist, and the clinic manager came in and he said, "You need a strap across your ankle." And I left that appointment sobbing and said, "I need something less restrictive. This is not helping me move." And I found an independent orthotist, and they have worked with me. And I will tell you, I was at my orthotist a week ago,
Uh-huh.
and she was commenting, watching me walk because she watches me walk every time,
Excellent.
and was commenting on how much better my movement was in the sagittal plane, and that she could see the tibial translation. And this is due to I have had a lot of interventions, and what was keeping me from that movement in the sagittal plane wasn't anything in the brace, it was my knee not bending. And so
Right.
that was the cryoneurolysis that has enabled more knee flexion during gait and has enabled better movement of the lower leg in gait.
Right.
But as
If you keep
regards to tendon lengthening, I
Mhm.
really have to recommend the Mayo Clinic, Dr. Peter Ree. He does a surgery, hyperselective neurectomy of the spastic equinovarus foot and ankle. And so it's a nerve procedure rather than a tendon lengthening procedure or a muscle procedure. And I was able to wear my AFO out of recovery and walk back in, and walk on it that same day. So it's much
Wow.
better than, and I could not be
Thank
non-weight bearing for any period of time. First of all, my home is not, my showers and bedrooms are all on the second floor of my house. So there's no way I could have, my home is not wheelchair accessible. So that wouldn't have worked for me. But I did the 6-minute walk test 4 days after surgery.
Mhm.
So that is much better if someone is trying to improve gait, to be able to be walking after that surgery. But after that surgery, my heel went from about this far off the ground to being able to stand flat on the ground just by changing the nerve signals.
Okay, so I have to preface this. It depends on where the lesion is in the brain and what's causing all of that nerve information to come down. That he had to snip because your other muscle group called the cortical spinal tract was so damaged, something else took over and it was sending information down, 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 causing your muscles and your foot to go down or either down and in. And so he had to cut off that firing. All right. But for other folks, the lesion may have not have been there. And it's just a muscle weakness problem from the cortical spinal tract. So it can't pull the foot up. So you just get drop foot and it's tight, not because of all this stuff firing down. So yours was a different premise.
Mine was spasticity.
Yes, it was. And spasticity is speed dependent. So when you put it on, it shakes. All right. So it's different from muscle tone, from muscle weakness. That's something different. So I just wanted to explain
Well,
that to everybody.
I had everything tight that could be tight. But
Yeah,
yes. And I
yes.
think most of the time when we're talking about stroke, you are right. There are people who are flaccid, and for the first probably several months after the stroke, I was flaccid, and then I needed an AFO that lifted my toe. But no amount of AFO lifting would have lifted my toe with the
It wasn't gonna work.
spasticity and excess muscle tone.
Right. And the reason why everyone's different, and yours was probably flaccid for months as opposed to weeks, as opposed to days, it depends on three things that I teach in my class: the location of the stroke lesion, the severity of the stroke lesion, and how large the stroke lesion was. Some people are flaccid and they're flaccid for the rest of their life. Some people are flaccid day one, and from the second day on, they're what we call hypertonic and have spasticity. So it just depends. Okay, Polly, your hand is still raised. And then Erica, did you have another question?
Yes, it's regarding my toes. So another
Uh-huh.
big problem I'm having is I have a toe curl, and
Yes.
my therapist recently put like a ball in the bottom of the AFO
Uh-huh.
that was supposed to relieve the toe, but instead of relieving it, it was making me more spastic. So we had
Okay,
to
I'm
remove the
gonna
ball.
tell you why. Okay. So when you're okay, this is my leg, and right here is the tendon that pulls the foot up. When your muscle doesn't work to pull your foot up or bring your leg forward, the natural response is to curl your toes so you don't fall backwards. You're curling your toes to help bring your body forward. So your toe curling is a result of your weak ankle musculature. All right. And so when you give the stimulus, and this is in my book, when you give the stimulus and you put a little bump right here in the foot, it causes you to do this. There are four pressure points on the foot that when you touch, it stimulates. So they just do this because, oh, we'll just do it on everybody. And they do that and it causes this.
Yeah.
So I've made toe spreaders that will fit in between people's toes, that will fit into their shoes and on their AFOs. And I make them larger at the big toe, smaller as you get to the little toe. So it's like an arch here. And I've done that.
And then in relation to what Polly was saying, I've tried Botox, and no Botox releases the muscle from tensing up. So then recently they sent me for nerve block, but the nerve block didn't work either. So I might be trying the Mayo clinic that Polly went to. I'm gonna look into it. And
So do you know,
Erica, you're in New York City, right?
Yes.
Miguel Escalon at Mount Sinai he is fantastic with cryoneurolysis.
So I'm going to reach out to you later because I don't want to take up Dr. Brown.
Okay.
Thanks.
So okay, here's the question, Do you understand why the Botox is not working? Because the Botox targets the lower motor neuron. You had an injury of the upper motor neuron. And so they're putting it into the space of the lower motor neuron. It doesn't impact the upper motor neuron.
Oh, I didn't
So
know.
that's the reason. Okay. And so what Polly had done impacts the upper motor neuron. A stroke is an upper motor neuron problem.
So the
Okay.
nerve block then essentially should be working, but it didn't work. And they've
Where
tried,
did they do the nerve block in your spine?
no, the bottom of the foot.
That's a lower motor neuron.
Oh,
Yeah. Yeah, lower motor neuron. Upper motor neuron, brain to the spinal cord.
so Polly's procedure was at the spine or the,
Well, it depends on where her lesion was and then where they did the cryoneurolysis. And I'm gonna let her answer that after when y'all two have a
move on, yes.
conversation. Because it's different for everybody depending on the lesion location.
Okay, thank you, Dr. Brown, and thank you,
Yes.
Polly. If you will allow, I'll reach out to you after this, okay?
All righty. So I just want to make a point out of this ankle foot orthosis. This ankle foot orthosis was for someone who is morbidly obese and their knee kept collapsing inward. So you see how this AFO is different? And then their foot kept rolling out. So that's a little shelf on the outside. But guess what? This AFO fit in her regular shoe. It allowed her tibia to come forward, and that plastic strap did not cover her anterior tibialis muscle that pulls her foot up, and the toes. And if you really look hard, you can see her big toe groove, a second toe groove, and a third toe groove. That's really flexible. It allowed her to take a step backwards, and you could see the crease in her shoe, and then load her heel. But she started out therapy very different in terms of her exercises. And I think that's one reason why most of my clients are doing well, because their exercise program is very dependent on where their lesion location is. Okay, so this is what I did. I asked people basically what they liked about their AFOs, what they didn't like. I just had a set of questions, and there were 6 themes that were developed. All right. The first thing was, they took pictures of their AFOs. They took a portrait of themselves with their AFO, and then they took a video of them doing something functional with their AFOs. So the first thing was that AFO took away my power of choice. I could not pick out the shoes I wanted to wear. I couldn't wear the clothes I wanted. And so the issue is, especially for the women, they wanted something that was flesh tone color. I had a lady who was a secretary and wore a skirt, and she says, I don't want the brace to be the first thing that people see. I had a young lady who had what we call extensor synergy pattern, and her foot was down all the time. She was forced to wear sneakers with a wedge on the outside, because if your plantar flex, that's the foot pointed down, the other one has to be pointed down also. And she didn't want to wear sneakers all the time with the brace with a sundress. All right. The next thing was the AFO characteristics. They're rigid, they're stiff, they're big, they're bulky, and they're heavy. So I took their AFOs and I started weighing them.
I'm in the waiting.
And they didn't weigh as much as a half a jar of peanut butter. The issue is the muscles were so weak, it was perceived as the AFO being the problem of being heavy, when it was actually the leg that they have to lift, tightening their pelvis. That was the perception of it being heavy. The third theme was AFO modifications and maintenance. So they would come in and have all these adjustments done, but when you adjusted one thing, it impacted something else. So this person said they heated it up and they moved it away from my foot. They put a pad in there. But when you put the pad in there and heated it up, the brace got wider. And when you put it in the shoe got wider and it came down and it rubbed the top of his toes. That's why I tell everybody you need to look at your toe shoe depth and how high it is, so that your toes can curl and relax and extend and do all of this in the shoe. Okay? And then we've already talked about this ankle strap. Because there was not flexibility in the ankle, and there was a tonus problem, which is in a spasticity problem. So the faster you move, you get this pistoning effect, which is like a clasp knife response, which is spasticity. And the strap didn't keep the heel in the seated part of the AFO. And then they said another theme was self-perceptions. I said, well, what did you think about you? What did you think in terms of, and they was like, it just looks uncomfortable. It's sad that I have to wear this for the rest of my life. And no, you do not have to wear it for the rest of your life. I've had people, depending on their lesion location, severity, and size, they've ran marathons. They are not in an AFO, and they started out in one. And then someone else stated, well, other people look at you like something's wrong with you. Well, there's nothing wrong with you. You just have foot weakness, or tone or spasticity or a sensory problem because you had a stroke. That's it. There's nothing wrong with you. You are still you. Communication was a problem. No one asked them about what is it that they do in life? What type of shoes do you wear? Why do you wear those type of shoes? They were always told you'll probably have to end up wearing a sneaker, a size wider and a size larger. You all, I wear a size 12 2A sneaker. I can't find a 13 if I wanted to, if I were to get an AFO. And I have very narrow feet. I wear a size 4A. It is so hard for me to find shoes. So I got to buy the narrow shoe to fit the other foot that doesn't have a brace. And then I got to find a 13 extra wide for the other foot. Who has the money to spend on 2 pairs of shoes?
I know.
All right. Yeah. I see the smiles on your face. Yes. So you have to think about all of that. And then I said, well, what would you tell the physical therapist or the orthotist about this whole situation about fabrication, fitting, function, and maintenance? They said, well, first of all, it needs to be a shared decision-making process. You need to ask me my opinion. And then when I tell you it, it needs to be respected and valued. And I want to feel like I'm being heard. Okay. So those were the 6 major themes. So I think we've had enough discussion about this, because y'all brought up a lot of things about your AFOs and the meanings in your braces. But did any of you have any other similar issues that was found in the themes of those research? I have 2 papers published with that. Yes, Polly.
I will tell you, last
Mhm.
year we tried to do the ankle control with an SMO like Musong showed, the boot that goes in the shoe.
Uh-huh.
And then was the first time since wearing an AFO I had to buy larger and wider shoes. And I could have bought 2 different size shoes, one to fit my right foot and one to fit the braces on the left. But I was worried, since I have such significant sensory impairment, I worried that a shorter shoe on the right would cause me to catch my toe on the left.
Yep.
So I wore an ill-fitting shoe on the right, and I actually developed Achilles tendonitis and had to go to physical therapy for Achilles tendonitis because of an ill-fitting shoe.
Yeah. See?
So I have 2 pairs of shoes. Exactly what you said, Polly. I have so my affected the AFO shoe is 10 and 10 wide. Then I have my regular on the other side, which is 8.5. So
Yeah.
that's what I wear right now.
And what happened to me was I got on treadmill training, and the minute she put it up to an incline
You
with
get.
the ill-fitting
Mhm.
shoes, I developed severe pain in the Achilles and wound up in physical therapy for several months to fix the right foot from just wearing an ill-fitting shoe. So just be careful of not wearing well-fitting shoes and
Right.
deciding, I don't know if I would make it. I think I need two of the same size shoe
You do. You
to
do.
give the good information to my brain about how to walk
You
since I
do.
have the sensory impairment on the left.
So what?
But now
You
I
do.
don't use an SMO and I will not use an SMO again.
So your foot is not ready for an SMO, but you're going to see coming up where I've taken some braces that are really, really high and I've gone down low because we've done the right exercise. But that depends on lesion location, severity, and and how large it is. So here's an AFO that fits
Sorry.
like a glove. And I asked the person if I could have it back because she doesn't need it anymore. But in some spots, it's really thin. And in other spots, it's thick. I can't move it. So the thickness differs based on the weakness, the tone of the muscle. And so when I was in Ohio, I started doing research with a scanner. And then you feed a program into the scanner and says, well, the muscles in the lateral compartment is a 1. It needs to be much thicker on this side. The muscles in the back is a 3+. It can be thinner. And so the plastic changes in thickness, and everybody's AFO for mine is beveled out and thin. So when it gets to the edges, it's as thin as a fingernail and it fits like a glove. But
Wow.
that comes with the art and the practice of understanding how to make an AFO. It's a craft that you have to learn. So once I started doing this, I take out the liner of the person's shoe. Everybody's AFO was fitting in their regular size shoe. Okay. I see something in the chat.
Oh, I was
Uh,
going
okay.
to say, no,
Uh-huh.
I was not able to wear an SMO. We tried. I was not
Yeah.
able to wear an SMO. I had to wear the SMO with the AFO.
Gotcha.
Yeah.
Okay, so the SMO, they get that from children with the DAFO, the dynamic AFO, and it's supposed to be volume socking, a socket fitting, and then you add the harder shell on top. So I've just taken that concept and made one AFO out of it. Okay, and then SMO is called a super malleolar AFO. It really has nothing to do with the inner shell because that inner shell can go all the way up. I had a cyclist, and her shell went all the way up. Okay, Ralph, do you have a question?
Can you show yours again?
Gosh, I just put it back on.
Oh, okay, then sorry.
That's okay. What did you have a question about? Sorry.
The boot that goes inside. People were asking what it was.
Oh yeah, it's the SMO. It's just an inner boot.
Yeah. So they call it an SMO, but it's not a true super malleolar ankle foot orthosis. It's the inner shell of that AFO to protect the ankle and everything around the hinge. You see that a lot with dynamic ankle foot orthoses that's made for pediatrics. Like everyone has an inner shell of their foot in the inside of their other AFO.
Yeah,
So
what
they
it did.
call it a SMO, but it's not technically a SMO.
Sorry for
I
interrupting you.
interject for a second.
Uh-huh.
Post-stroke, when I was given the AFO that had no hinge and I had
Uh-huh.
to attend work, I wanted to wear my shoes. I refused to buy 2 separate shoes and I started wearing an ACE brace. And I was
Okay.
able to wear my ACE brace and train with my ACE brace and get strong. So I think that I'm able to, if I could just relieve the toes. So any suggestions for relieving the toe and wearing my ACE brace, that would solve all problems for me.
So you need to get the toe flexors. You got 4 sets of muscle layers in the bottom of your foot that help bend your toe, plus your long toe flexors that come at the back of your leg. So I tell people to start with different size diameter. You can start with a pin, then something wider than a pin, then a rolling pin, and you have to roll it and get your toes stretched like this. Then you have to stand up, load the forefoot, and
Yeah.
then step backwards. You'll see some pictures coming up.
Thank you.
All righty.
Thank you.
Markers are good. The markers, pencils, markers, and you start rolling. You come here, then you roll backwards, and this is how you want to end up. And then you have to roll it and roll backwards. Okay, so study question number 1. What was the AFO impact on stroke recovery? There's 2 things that's going to happen. You want to start walking and you want your muscles to get stronger. All right. So a good thing about your AFOs is that it provides stability, but it can often be a barrier to performing certain activities and prevent the return of movement. The number 1 thing is that strap across the ankle here. All right. So when the AFO is stiff at the ankle part and your leg cannot come forward because of the bandages or you have increased tone, you compensate at the pelvis or the hip. You cannot walk like step over step up and down, but we teach them up with the good, down with the bad. I don't teach my clients that. They go step over step and their knee is allowed to bend and come over and in front of the other leg. And they go up and down stairs sideways and backwards as well as forwards. All right.
Do you have
And
do you have
just
a video of that posted anywhere?
probably not, but I have pictures.
Okay, great.
I will see if and I have pictures of me doing it with someone that really has a stiff leg. So if we have time at the end of this, I'll pull up that PowerPoint because I teach from that PowerPoint of that. And then just because you take the AFO and release the tension in the hinge and make it more springy or more bouncy or anything like that, does not mean you increase ankle strength per the research, nor ankle range of motion. You've got to do the work, and there cannot be brain damage to the cortical spinal tract that goes to the foot and ankle for that to improve. So just because you decrease the AFO stiffness doesn't mean you automatically improve the strength of the ankle. That's lesion location severity dependent. Okay. Another big thing about stroke recovery, because people won't
So what
walk.
can you do with that? Sorry, what can you do with that when you have that? When you have identified that, what can you do? What's the
I
protocol for
I teach compensation. I
that? Okay.
teach compensation. Yeah, because once you have that so much damage in the stroke caused so much damage to the cortical spinal tract that there's nothing else that can take over that will pull the foot up. Then other things starts to beam down. Okay. And so I at that point I teach compensation, and you'll see some compensatory things that I'm going to show you all that will help maintain range of motion at the ankle, but you have to do it constantly. And if you don't do it
Okay.
constantly, you end up getting something done like Polly did. Okay?
Okay,
Or
that'd
the
be
other
great. Yeah.
option, that I talked about. So people want to be able to walk. They want to be normal. All right. But it's a psychosocial barrier because it limits the choice of clothing and shoes. You all be surprised how many people who do not go places because they can't wear what they want to wear. I live in a southern city, and women will not wear sneakers to church. You don't wear sneakers to church with a dress. You just don't do that. All right. And so I was forced to make a better fitting AFO based on lesion location, severity, and size, all right, to accommodate the persons, all right? And then I remember one person telling me it creates a sense of abnormality. You have your foot sticking up in the air because it's in the AFO, but the other foot is able to rest on the ground. So you're not abnormal, but it creates a sense of abnormality. The body part, all right, is there something wrong with the body part? There's not necessarily something wrong with you as a person. So question number 2, how does the AFO make you feel? Like you're an object, or does it provide the ability for you to engage? All right. So people were very self-aware that this AFO allows them to change their body schema and how they feel about themselves. And once they realized that they could do more things, they were more aware of that, they became more independent, whether their foot worked or not. The AFO helped provided the stability that they needed to move. And so they became more independent, more confident. But that was a self-awareness. Some things are going to get better and some things won't. And when they were made aware of that and found a way to navigate and negotiate that, they became much more independent. I think we need to reframe what stroke recovery means because everybody wants to return to normal. But just think about it. If you want to return to normal, do you really want to return to the habits that you had? Okay, it may have been a medication issue. It may have been a sedentary behavior. Your nutrition wasn't well. That's what you want to return to, okay? Because that's not what you want to return to. You want to return to a behavioral set that will improve your health outcome from here on out for the lifespan. That's what you really want. And again, depending on how much damage there was to the what we call the corticospinal tract, your motor tract to make your foot move up and down, in and out, you may not return to normal, right? And that's what therapists, I think, are failing to explain to our patients and our clients. When people wore the AFO, there was some ambivalence towards it. That means, oh, I got to wear this for the long term. Okay, if I have to wear this for the long term, that means I'm not going to be normal. Okay, you may feel that way, but the AFO provides the opportunity for you to walk and engage. It may not look normal, all right, but you're able to get about and move. And I think it was so important when Polly said, I was able to do the 6-minute walk test with my heel touching the ground. That walking, that distance in a certain amount of time is the best thing for your heart health and your brain health. That's what's really important. You want the best functional outcome for your health span, for your lifespan. So I think, again, we need to move away from this thing of what we think is normal and look at it in a sense of what is healthy for us for the outcome of our lifespan. So there really is, when you look at the research, and my research proved it, there's this mismatch between the value of gaining strength in the foot and being able to pull it up versus wearing the AFO and being able to walk. People would rather do without the AFO. Some of us is going to need the AFO, and some of us can do without it. But what's best for your heart health and your brain health is that you move. And what's the easiest and the cheapest thing to do in terms of moving? Safe walking. So if you need a brace for safe walking, I would choose the brace for safe walking because it's the best thing for heart health and brain health.
Totally agree.
Yeah. So what really matters? And when it all came down to it, communication. This is what all my clients or patients with stroke wanted to know. Will I walk again and will my strength come back? And I have to take the time to explain to them about this cortical spinal tract, where it was damaged, how much it was damaged. When it's damaged here, these other things take over and it makes your foot turn down and in. Or these things took over and your foot is going to be floppy for the rest of your life. And you really have to know and understand that and be able to tell it to them with compassion, but tell them it doesn't stop you from being a mom. It doesn't stop you from being a lawyer. And we're just talking about poor Miller strokes now. We're not talking about all the other things that take over. And then we have to have an opportunity for them to engage in shared decision making. Okay, so now that I've told you that, and these are your options, what do you want to do? And then it's my responsibility to say, okay, you want to do this? For your best outcome, you need to do it this way with this type of brace. And that means I need to know how to make the best kind of brace, and I need to know the best type of exercises for them to do. And then it's on them to do it. But I can't say do 20 reps. I had this happen today. Someone was told to do like 20 reps 3 times a day. But when she comes to exercise class, she's just flailing her leg up and down. And I said, momentum doesn't make a leg strong. If you all did 10 the right way, and according to the 10-second count, you would be fatigued. You don't have to do 50. And she admitted that. She said, well, that's what I was told to do. All right. So sometimes I think we as therapists, we need to step back and look at and look at ourselves and saying, why are we telling our patients that? Is that truly what we do in terms of exercise and how it should be done? All right. Because 10 done the right way is better than 50 done sloppy. All right. When you look at the research, what people say about their AFOs is not being considered and respected by the people who have to recommend the AFOs and make the AFOs. All right. The orthotists are really good at making AFOs for the technical aspects, but the technical aspects do not parlay into social determinants and engagement of the person. So the orthotist may be really good at making this AFO for the mom who had a hemorrhagic stroke postpartum after having a baby. But the orthotist doesn't understand that she wants to be able to get down on the floor and kneel and play with the baby. It's going to take a different type of AFO. So unless you have a good physical therapist that does movement analysis and measures everything and gives that information to the orthotist, the communication is key. That's what matters. So this is the gentleman that had that AFO. If I did not loosen the strap, he couldn't get his knee forward. He would continue to have hyperextension. You can see the line right here where I shaved it off. All right. You can tell that I tried to tape his leg for it to work, didn't work. But now he can go to sit to stand without using his hands because his knee is not blocked. All right. And now he can get his ankle behind his knee. And these are spandex straps. So what can we do to change the AFO fit and function? All right, your occupational therapist, since they deal with your daily living skills, they should ask you what you like to do. Did you regularly engage in exercise or physical activity prior to your stroke? Because if you told me you played ping pong, every exercise you do is going to be in a stance phase at a table, and that's how I'm going to engage you to do exercise so we can carry over into ping pong. I am not going to make you lay flat on your bed and try to bring your knee up to your chest for your exercise. You need to do a different type of exercise, especially if you have a lot of tone in your leg. All right, you need to be weight bearing and loaded. All right, bring your shoes that you normally wear to your PT appointment, and then the extra large size shoes that you bought for the AFO. And the reason why I want you to wear your shoes that you've been wearing for the past year, because I look at the bottom of the shoe and I see where you've worn it, and I look at the inside and I pull the sole out and I see your weight bearing foot. And then I make all of the AFOs to look like the bottom of your foot. None of my AFOs are flat. Your feet aren't flat. None of your feet are flat. Your AFO shouldn't be flat. It should look like the bottom of your foot. It tells me a lot about your walking habits. All right. And then I can analyze your walking in this plane and then that plane. And then I can stand over you and tell you to take a step, and I can see how your pelvis is rotating. Half the time your pelvis doesn't rotate because you don't roll over your toes and bend your knee. So your pelvis, your hip stays behind you and it doesn't rotate forward. Okay. So what should the PT do? And this is the point that Masson had made. I measure the ankle range of motion in 3 positions: laying down flat, sitting in the chair, and standing up. And I measure it with the knee bent and the knee straight. I measure for a contracture. So I take 2 measurements, the first feeling of resistance, and then I push it a little bit more for that final feeling of resistance. If that number is 3 or so degrees, there's a contracture. I need to refer out. And then I have to do some other tests to confirm, is it a neuro problem or is it a musculoskeletal problem? More than often, it's a musculoskeletal problem. Some other tests will tell me if it's a neuro problem, and all of that is in the chapter in the book. All right. And then that will tell you who you're going to go to and see for the surgery. But can anybody tell me if your PT measured your range of motion laying down, sitting, and standing?
Nope,
Anybody?
nope.
Yeah. See, and that's what makes for a good clinical specialist, because I have to mimic sit to stand, standing, and walking for the range of motion. And when I measure it in standing, I will know whether your heel is going to pop out or not. And if your heel pops out or doesn't rest on the floor, like Polly said, then I need to add a little wedge. And all of that is in the book, whether you're going to add a wedge on the outside of the AFO or the inside of the AFO. Okay? And when it says assess for ankle muscle function, I don't want them pull your foot up, push down, don't let me move it. They need to measure those muscles isometrically, concentrically, and eccentrically. We're only taught one way in school, but there is something in the old version of the book that teaches us how to do muscle strength testing on how to measure the muscle activity, what we call eccentrically. Gait or walking is highly eccentric, but I bet you if I were to come take an assessment of all your exercise programs, y'all wouldn't have one eccentric exercise in the program. Most of the exercises we give you all are open chain. That means your foot is not touching the ground, it's moving in space, or we tell you to pull your foot back with a band or a sheet or a belt. Okay? So again, isometric, concentric, and eccentric. So here's another gentleman who started off with a tall AFO, and you can see the lines shaving stuff down. He didn't need all of this. This is how he started out. And he did a certain set of exercises, and you can tell his anterior tibialis muscle and his calf muscles are fired up because I didn't block his knee from going forward. His strap is not coming across the top of his ankle, blocking the tendon to pull his foot up. This is the same AFO. He did not get it. Don't believe in spending people's money. He got the same AFO and it changed over time as his body changed over time. And why do I think his body changed over time? He got good acute stroke care. He didn't have that much damage to his motor neurons. He got good post-stroke care. And based on where his lesion was and the severity of his lesion, I gave him a different set of exercises that nobody else had. All right. So remember, the AFO is made for stability, not for making changes over time. I just had a paper published in April about asking therapists, what outcome measure do you use to assess whether the person's AFO is functioning at best for them? And then do you give this information to the insurance company so that they will pay for changes? Because they don't always reimburse for these fancy things that I need for an AFO. So I've generated a letter of medical necessity based on my years of experience. This type of lesion, you get this type of outcome. They're going to need this type of brace. If they have these things going on, I'm going to have to add this. This is going to be this. This is going to be that. Over time, I feel that if they do this and this, they can have this change in the brace. I write that in the letter of medical necessity. And that's my experience, clinical expertise, my research background, and I put all that in the letter and I send it to the insurance company for reimbursement. The thing now is that most orthotists don't want to make the AFOs and they get them shipped out or they get off the shelf AFOs, small, medium, or large, because they're not getting reimbursed for them. When prosthetics got the AMP Pro and the AMP No Pro outcome measure and started using it and sending it into Medicare, private insurers, that's when the quality of prosthetics got better and they started paying for them. They pay $30,000 for the computerized knee alone. All right, so people are getting reimbursed for these prosthetics, but we're not getting reimbursed for the orthotics, the ankle foot orthoses. All right, we finished up this section. Do y'all have any questions for me? I'm just looking at things in the chat. Someone's thinking about adaptive cadence sneakers. If that's the one with the rounded toes, just remember you're forcing the rocker at the bottom of the shoe. You want your heel rocker, your midfoot rocker, and your toe rocker to work. And you should practice that without the sneakers. Erica, it will get better once you find the right person to work with you. And that means the therapist and the orthotist. It's communication. It has to be a team. It has to be a team. Okay, so what can we do? AFO and exercise. Okay, so just look at this video. Notice her foot is not coming up at all. She has toe drag. But she has potential to move her calf muscle. It's firing up in the back. Okay, and so this was the AFO that she got. One thing I didn't like about it, and I had to train the orthotist to do this. My toe plate was flexible, but it was flat. And I said I needed to be rounded. All right, not the round right below the toes that caused this, but I needed to be rounded here at the transverse arch. Notice this part was really contoured to her foot. All right. She didn't, when you noticed her walking, her heel wasn't rolling out or anything like that. So she had good stability. So there was no need to cover up her ankle. All right. So that was the only thing she changed. When she went to sit to stand, her knee could come forward, and this AFO was flexible enough that it could move with her. All right. So remember, I told y'all, depending on where the weakness is in the leg, the front, the side, or the back, my AFOs are not that rigid that you can't move them with your own power. She could move it. I just told her to relax her knee, and her AFO came forward, and she had a little space in her knee. All right. And so I try to make it loose in the ankle part so that they don't rub a lot. Now, how did I fire up her lateral compartment and her front of her ankle? I didn't have her doing the exercise where she's turning her foot out like this. I didn't have her doing the exercise where she pulls the foot up like this. This is what you call isometrics. It's a holding stabilization exercise. I made her step sideways and then she had to step forward. That's the exercise. She's working on her balance strategies. She is loading the foot and ankle for proprioceptive and sensory input. So she started off weight bearing and doing a simple exercise. She wasn't moving the leg. She started off weight bearing. So we started off in stance, phase, control. Stance, phase, control. And then when it was time for her to roll over her forefoot, she had to relax her knee. So I was teaching her to stand and just relax her knee because it shouldn't be locked straight at 0 degrees. I never tell my clients, oh, straighten your knee, straighten your knee. No, you got to squeeze your butt to get your hip over your knee. And then the other leg is swinging through. So stance, phase, control. That was her exercise to activate her leg. Okay, remember, she couldn't pull her foot up when y'all saw her walking, but look how her anterior tib muscle is firing up here. That's the muscle that pulls your foot up. If I had a rigid strap on here, you wouldn't see that. Okay, and because her leg is coming forward, she's firing up her calf muscle eccentrically. It's allowing the leg to come forward, and that's what you need during gait.
I'm noticing also her AFO is so low. Are most
Yeah,
of
because she didn't need, and did y'all notice that she wasn't bending her knee a lot during swing phase, nor her hip? We make that AFO high because we were taught that. If she didn't need it and she wasn't hyperextending, there was no need to give her a tall AFO. I want her calf muscle to expand and contract. So therefore, I didn't give her one. All right. So now she's sitting at the edge of the mat. Her exercise is to pull her ankles back. That's all she has to do. I'm not worried about the heel dorsiflexing. I'm worried about the knee working to pull the ankle back. So y'all just take a roller pin, put it under your feet, and bend your knee. Okay? We got to get the ankle behind the knee. And then I'm trying to load it. For all of you whose foot you say is rolling in, you need to stretch what we call the posterior tibialis muscle that's pulling that foot in. How do you do that? You can put a door stopper under the lateral part of the heel. I put it this way, and then I have the wide part to the back. I put it at the hind foot, the midfoot, and the forefoot. Once I get to the forefoot where the toes are, I put it under the fifth toe, the fourth toe, and the third toe. You don't put it under the first and second, because remember, I told y'all that little arch, I want it to drop down. And then she has to stay down there. She has to load her leg and stretch her leg. Okay? So she's loading her leg. She's doing things, putting stuff on the floor, moving around. She's moving it from her left to her right because I got to get the ankle strategy working. All right? And then we start with some lifting the things up. Notice her right foot is the weaker foot. I said only lift the left. Because when you lift the left leg against resistance, the brain says, my left leg is lifting up. Well, shouldn't my right leg be lifting up too? I said, don't worry about lifting up the right one now. I want you to lift the left up against resistance. Look at the bottom picture. Look how nicely she can lift her right leg up first. But I started all of her exercises isometric weight bearing and loading first. Okay. I activated it through weight bearing and loading first. All right. She didn't have all these open chains. I need you to do 20 toe raises. Nuh-uh. We loaded the body first. All right. We loaded the body first, weight bearing. And then we started moving up the chain. So she needed to bend her knee. She wasn't bending her knee. Notice it was hard for her to do the concentric, which is the shortening, her hamstring, pulling her leg up. So I helped her pull it up. And then I said, you're going to lower it down to the floor slowly, eccentric. And I want your toes to touch the floor first. And then she gets the hyperextension of the toes, which prevents this, that, and then she loads the heel and comes down. Okay, now that she has stretched the hamstring muscle, lowering it down, quickly pull it up. I'll help you. Come on. So passively, I put the leg up. You're going to slowly come down, touch the toes first, load the toes, then the heel, stretch the hamstring, quickly pull it up. Now look how she is progressing. Remember, she wasn't pushing off on her toes when she was walking. Now she can put her strong leg bent in a chair and raise up on her heel on her weak side. That took a lot of work. And look how nice her calf muscle looks. Remember now, she had an AFO. I'm strengthening her in the AFO and out of the AFO. How many of you at your last therapy session had someone take off the AFO and strengthen the muscles of the front, side, and back of your leg and foot? Anybody?
I opt to do that myself. So there are days that I go to therapy with just the ACE brace.
Uh-huh.
She'll work with me like that. But it's not
Okay.
that she has asked me to do. I tell her I really want to train my muscles. I'm going to work safely. And we do. And on those days, she'll sit me on the bike. She does a lot of safe work.
Okay, but the safe work isn't helping you. And when you pedal that bike, make sure you're pedaling backwards and up, okay? And make sure it's an upright bike, not a recumbent bike. Do they have an upright bike?
So they do on the other side that I've requested to go to, but I have not gone there. So I
Okay,
took
tell
my
him.
own Peloton. I've done my own. So I do.
Okay, so you need an upright bike to help strengthen your gluteal muscle. When
Yes.
you're sitting down in a recumbent bike all the time, you're not using your glute muscle. And your glute muscle and your plantar flexors, the muscle in the back of your calf muscles, is what helps you push off and walk faster. Okay?
Thank
So
you.
now, you're welcome. Now I want you to look at the video at the bottom. So this is a person that I just took the shoe off. She still has the AFO on, but I took the shoe off, and I do believe on her AFO, I took off the strap that it came with, and I put a spandex strap on. So let's look at this one. So what I'm doing is I'm counting, and see, she can pull her foot up. It's coming off of the brace. Now I add resistance at her knee. Sometimes we're putting the resistance in the wrong place to facilitate the tibialis anterior muscle that pulls it up. Now look at this video. Ooh, look at there. I put the resistance at the distal part of her knee, and she's holding it down with her opposite leg. She can do this at her house on her own. Would you have ever thought that her ankle had that much movement? And she came to me with this AFO. I didn't think she needs anything different, but she needed to be trained on how to improve her ankle function so she can wean out of the AFO. She was a good candidate to wean out of the AFO. Okay, so y'all see the difference. For those of you who have a tight heel cord, everyone gives you the picture where you put the foot on a sheet or a belt, but if you have a weak arm, you're pulling towards the opposite side and you're turning the foot in. So first of all, the belt or the sheet is not low enough to capture the thing to move the heel. All right. So I tell people, if you're going to use the belt or the sheet, you take your strong arm, if this one is weak, and you need to pull towards the hip on the same side so you get a straight line this way, not this way, because you're going to pull towards your strong arm. I need you to pull towards your hip. What I really tell people is that I need you to load your ankle. So if you're going to sit and watch TV during a certain time of the day, if you're going to be on your computer, I need your legs crossed and I need your ankle behind you. And I need you to load your ankle. All right. And then I need you to take your upper trunk. All right. After you've crossed it, and put the weight of your upper trunk, all right, onto your thighs. And that makes for a good load. You take that door stopper and put it on the lateral part of your heel, your midfoot, which is the lateral, meaning the outside of your heel, your midfoot, which is the mid part of your ankle, and the forefoot. All of those descriptions are in the book. And then I tell you to reach forward and hold it and load their leg. All right. Bring the ankle behind the knee. All right. And load the leg. And then in that position with your arms up, with your ankle behind the knee, try and stand up. Stand up without the door stopper and with the door stopper. And you'll feel the movement in your ankle. That's your ankle rocker. And it happens in 3 places: the hind foot, the midfoot, and the forefoot. When you go from sit to squatting position, you don't have to stand all the way. You're really working the hind foot and the midfoot. Okay? Based on where you put the door stopper. So do y'all have any questions for me based on that treatment? How to control and improve the rolling out. So you need this is the wrong side because this is the inside, but you see how this moves and it's flexible? You need to have one on the outside over here to prevent it from rolling out. Or this, if it comes out further enough, will prevent my foot from rolling out like that. So either way, it depends on where the rolling out is coming from and what's it contributing to, what's causing it. So it depends whether you're going to have the flap on the lateral side to prevent it from rolling out, or you're going to have it on the inside to prevent it from doing this.
Could you hold it up again so I can take a screenshot of it?
Yeah, so this is the wrong side. This
I
is
have in though.
this is the on the medial side of the foot. So if the person's rolling out, this will stop the forefoot from doing this. But if it's the ankle joint, if it's here, you need this to come further. And all of that is described in the book.
I'll just get the book. Okay.
It truly is in the book.
Thursday. If I can get it by Thursday, because I'm gonna see them on Thursday. And I've never seen that part that
Okay.
hits you from rolling in or out.
Okay, so if you're rolling in, you're overpronated and your knees will come to the middle of your body, and that's because your tibia can't come forward.
Yeah.
That's when you're excessively rolling in. But if you're rolling out, you're landing on the outside of your foot, the lateral part of your heel. That's why I tell everybody to bring the shoes that you normally wear so I can see your normal wear and tear pattern on your shoe. And I take the liner out so I can see the weight bearing of your foot, because you don't want to change your normal wear pattern. You don't. You want to fix the issues from the stroke and allow them to get better. For the people, depending on where their lesion location is, and you can tell from the lady, y'all saw the video. She can pull her foot up. She wasn't bending her knee. She wasn't bending her hip. And by the end of therapy, she could put one knee on a chair, her good knee on a chair. She can't use it. She had to push up through her ankle. That means her calf muscle was working. She could balance on her toes. She didn't have her AFO on. So she started out with an AFO and she weaned from it. How do you stop your heel from lifting up off the floor? It's tight. And the tone from up here, the information from down here is shooting all the way down because your cortical spinal tract was damaged, and either it or its kissing cousin called the rubral spinal tract is telling that other tract, you need to stop sending all this information down to my foot. It doesn't need it. So a lot of your movement that you see that we call normal and graceful and is because of inhibition. When you've had a stroke, the inhibition is lost and everything just comes down from your brain and fires off through your spinal cord, and your spinal cord doesn't modulate it. Your spinal cord is a conduit of getting the information out to your lower motor neuron. It doesn't say, I don't need you. It just lets it comes through. So when you can't, if you can't stop your heel from raising up from the floor, the musculoskeletal tendon is tight, or the input from your brain from the lesion is just keeps coming down, coming down, coming down, coming down. And there's nothing in the area of what we call the basal ganglia to communicate to it to stop it, because that's where most of that communication starts. You're welcome. Any other questions?
Yeah,
Okay.
I've got one from the YouTube.
Uh-huh.
They're asking about the heel up. Obviously, it's a stroke pattern for your toe to point. I've always told people that the only way to get the best way to get your heel down is weight bearing. Do you have
Yes.
any other suggestions or?
So first of all, you need to determine if you have a contracture or not. So the physical therapist needs to measure your ankle in those three positions with the knee bent and the knee straight and determine if you have a contracture or not. If you have a contracture, you're not going to get your heel down. So that's the first thing that has to be determined. If it's 5 degrees or more difference, then you have flexibility. You need to load that heel. Every time you stand up and you lean to the strong side and use your hand, you're not loading your hemi side. So you
Correct.
need to load the leg. But the first thing is to see if you have a contracture or not. And I explained the R1 and the R2 in the book.
Thank you.
All right. So everyone's been asking about the book. Here's your screenshot. Here's your screenshot.
And by the way, for everybody watching today or out there in YouTube land, I'll put the link to the book and all of Jennifaye, Dr. Brown's contact information in the description underneath the video on my YouTube channel when I post it.
All right. And here's the chapters. Notice I have definitions and pictures about a lot of things that we talked about. I'll differentiate muscle weakness, paralysis, tone, spasticity. I explain what foot drop is from an upper motor neuron lesion for having a stroke versus a lower motor neuron lesion. I describe all parts of an AFO. I explain why you need one. And then I have a whole chapter on what your physical therapist should do, including the examination. And then questions you should ask your physical therapist. Then I have a whole chapter on what the orthotist should do based on my experience. And then the questions you should ask the orthotist. All right. And then what you should expect when you get the AFO. All right. And then I hold you accountable too. You need to do some things once you get that AFO. And then some physical therapy pearls from my career experiences. I probably don't go into that much detail about isometric, concentric, and eccentric exercise because that's a whole new book. And people have started bothering me about that book. But that's not going to be a book per se because people just don't read anymore. And we're trying to come up with a way where it's going to be a video book or a movie of some sort. And I'm going to do the exercise, but we got to do it based on lesion location and all those things. And then we have to tell folks that you need to modify each and every exercise based on you. But that's what I think we're failing to do as therapists because you only got so much time. We quote unquote got to get you functional, but we never teach you anything for the long term. We teach you goals for the time that the insurance is going to pay. And when you've met your goals, we discharge you. But we need to teach you things that you can be doing for the lifetime of your health span. All right? Because you want better health across your lifespan. And then the book has the my thoughts on everything, and then references, publications, and all my presentations. And again, if you get anything out of this, you don't know what you don't know. And so somebody has to make you aware of that. But then you all need to make us aware of some things too. So I tell people you need to talk to achieve your best walk. And I don't care if the people aren't listening to you, you still talk. Tell them what you do at home. Tell them what's important to you. All right. And we're the experts at our professions, but you're the expert at your lived experiences. And we need to make sure that you all get back to living. All right. And that living needs to include exercise and physical activity so that you can have good heart health and good brain health after your stroke. Okay.
Polly's got a question.
Yes.
I was just gonna say you asked me if it was comfortable, and I wear my regular size shoes and use the regular shoe insole on top of the foot plate. So sensory deficits don't let me know if it's really comfortable, but at least it is not, oh, here is a problem I had. And you can see where the foot plate is actually cut out to accommodate the varus.
Yes. On that side. Yes. Yes.
So
And so I think those carbon fiber, those braces are getting better. They're getting better, but I've seen them broken. I've seen them broken. And that just tells you that people are extensible and they move. And so it needs to be stable and rigid in some places, but it has to allow flexibility in other places. And that's why I like the band. I don't mind that brace. The only thing I don't like about it, it doesn't have a band with tension to allow the calf muscle, the lateral muscle, and the anterior muscle to get stronger. Because as long as you're fixed, your muscle's not going to get stronger. And then the toes are perpetually up like this in the foot plate. Nobody's toes are perpetually up like that. So those are probably the two things. But I've seen a lot of people do well in those braces. And I've gotten them, my patients, and I've modified them. And they're happy with them. If it's
Oh, and
working,
there was one other thing you talked about that I have had this heel wedge in
yeah,
my shoe since 2018. This
okay.
same one.
Uh-huh. And so when I give my clients the heel wedges now, I give them the ones that have the layers that can peel off. So month 1, you get this, peel off a layer. Month 2, get this. Month 3. And I said, well, how do I know to peel off the layer? You get the range of motion measurements from your physical therapist. If your range of motion improves, you take off the layer. If you're doing the exercises and you don't have all this information coming down your brain, causing you a lot of problems, then your range of motion should improve. I am from the school of thought, depends on where the lesion is, that muscle strength can override spasticity and tone, but it depends on where the lesion is and the severity of the lesion. Someone said, I wish you could train all the therapists. Believe you me, I am trying. I got a request to go to Alaska in the fall. I hope I get to go. I think I'm only knowledgeable and thorough because my clients have trusted me to try things that they needed. And so you got to build trust. It's all about communication. I'm only as good as what I can impart on my clients, and they trust me to do it and they get better. And I know that they're going to get better because I understand my neuroanatomy, lesion location, severity, and a size of the lesion. Because the size matters because it can impact your sensory nerves. It can impact your vision nerves. It can impact your auditory nerves. It can impact a whole bunch of things. Okay. Is there anything else? Okay, we got to go. So on the very last part of that slide,
Oh,
there
sorry.
is on the very last part of the slide is I wanted to show some pictures of the AFOs. If they don't buy the book, they're not going to see it. So do I need to go back and share the screen so that they
Sorry
can see
about
the
that.
pictures?
Sorry about that. I unshared it.
Okay, so
I
hold
thought you
on.
were done.
I want them to see the pictures. Here, we'll just do this one. All right, do y'all see that?
It's working on it. There you go.
There you go. I've made a whole bunch of different AFOs for a lot of people, and I don't use hinged AFOs. I've made AFOs for people in their homes out of fiberglass, and then they take this prototype to the orthotist, and I tell the orthotist to make the same exact thing that they're wearing. I've had people who've taken my brace, gone to the orthotist makes it, and because the way they make it, it doesn't turn out the shape of the person's foot, and they've gone back to wearing my AFO and wanted to know if I can make another one. But they really do need a clean one. So notice how all of these are different. This is an off-the-shelf one that we shaved down and heated up and put it away from the body, and we added spandex strap. Okay. This book is
Right.
available at Amazon, Barnes and Noble. I have an ebook. If you want an ebook from me, you have to go to my website. Now we're done.
Okay, sorry about that.
That's okay. I'm going to stop the share.
Thank you.
You're welcome. You're welcome. You're welcome. I'm buying the book. Thank you for buying the book.
Me too. I just got it
Tell
on Amazon.
tell your neurologist that they need to get it, your primary care physicians, tell your therapist. I mean, I'm only one person. I can only spread the news, but so much. And I'm trying. But
it. I'm
thank you all for your attendance. I do answer emails. I'm
Okay.
slow with it, but I do answer emails. I'm not a TikTok person. I'm not on Facebook. I'm on LinkedIn, and I do have a YouTube page, but I'm trying to post the right thing on YouTube for people to get information, and that's coming.
Well,
Okay?
thank you for taking the time out of your busy schedule, and I mean, you stuck around, you answered everything. You put your presentation on hold for 10, 20 minutes at a time, and all the people that you answered, as well as myself, and everybody out there in YouTube land appreciates it. So thank you, thank you, thank you.
Yes,
All
thank
right.
you. Thank you.
You're welcome.
Thank you.
You're welcome. Someone asked in the chat, what's a good diet for brain health? I'm gonna just tell you right now, we need to stop eating the sugar. We had a cholesterol problem that used to have cardiovascular disease and stroke. Now it's the sugar. It's the sugar. And we are eating too much processed food that's laden with sugar and salt and chemicals. So if you can do fresh fruits and vegetables and pasture raised meat that they don't eat all the chemicals, that's what's good for you. But just read the box of what you're eating in the house. All right?
You shop the outside of the supermarket because all the processed foods and chemicals are in the aisles.
Great.
That's right.
And if you can't pronounce it, I won't eat it.
Right.
And
And
if I pick up something and the ingredients are this long, I don't even read them. I just put it back.
and if it sits on a shelf, it sits in your colon, and that's why colon cancer is on the rise.
Ooh,
If it sits on the shelf, it sits in your colon.
I might have to borrow that one.
Yeah, you can. You can. If it sits on the shelf, it sits in your colon. Okay, everybody.
All right, thank
I
you.
love this group. Thank you, Ralph. Thank you. I so appreciate you. Thank you, Polly, everyone. I love you, and I will see you soon. Next
Bye
week.
bye.
Bye, everyone.
Bye
Bye.
bye.
Bye.